So here to talk with me this morning about that is U.S. Surgeon General Vivek Murthy. We'll have a conversation for a bit, and then we've asked our investigators and all of their teams who are working on HEAL to submit some questions to us that they thought might be good for us to talk about as part of this conversation with the Surgeon General. And we'll come to those in a bit. But without further ado, let me introduce the 21st U.S. Surgeon General, Dr. Vivek Murthy. He served as the 19th U.S. Surgeon General also and was confirmed by the U.S. Senate on March 23, 2021 as the 21st Surgeon General. In his first term as America's doctor, where I had the privilege of working with him, Dr. Murthy created initiatives to tackle our country's most urgent public health issues, including addiction and the opioid crisis. He issued the nation's first Surgeon General's report, presenting the latest scientific data on addiction and issuing a call to action to the nation to recognize addiction as a chronic illness and not a moral failing. In 2016, Dr. Murthy sent a letter to 2.3 million healthcare professionals, urging them to join a movement to tackle the opioid epidemic. This was the first time in the history of the office that a Surgeon General had issued a letter calling the medical profession to action on this issue. In 2017, Dr. Murthy focused his attention on chronic stress and isolation as prevalent problems that have profound implications for health, productivity, and happiness. That laid the groundwork for his 2020 New York Times bestselling book called Together, The Healing Power of Human Connection in a Sometimes Lonely World. So welcome, Dr. Murthy. We have known each other for a few years, and I know the interconnected issues of emotional well-being and loneliness have been top of mind for you, as has the fight to end the opioid crisis, and they're connected. You've talked extensively about the national epidemic of loneliness, and you've traveled the country hearing from people about it. This is a particular problem for people for whom the NIH HEAL Initiative is trying to help. So what have you learned along the way about how loneliness affects emotional well-being?
Well, thanks, Francis, for that question. And before I jump in, let me just say a thank you also to you and your staff for having me, to the HEAL investigators who are here today for the extraordinary work that they do. Francis, when you were reappointed to be NIH Director, as a friend, as a colleague, and most importantly, as an American citizen, I just felt so grateful that our country was going to have your leadership for more years. So thank you so much for everything you've done. And to the investigators who are joining us today, and I know that the opioid epidemic has been really swept off the front pages and off of much of media coverage over the past year, as people have focused, in many ways rightly so, on COVID, but the struggles have not disappeared. And in fact, having a report of nearly 90,000 overdose deaths from September 2019 to 2020 was yet another stark reminder that the challenge remains. It has grown in many quarters. And it was a reminder to me that the work that all of you are doing, the problem that you have been focused on, is so absolutely important. And so I'm just deeply grateful for all of your work, despite the challenging times. The issue, Francis, you bring up of loneliness and perceived social isolation is a profound challenge for communities struggling with addiction across the board, including but not limited to opioid use disorders. This is something, to be honest with you, I had no real background in, when I started my time as Surgeon General, but I was really educated back in 2015 by people I met all across the country, who in their own way would tell me their stories of isolation and loneliness. And these are familiar stories to me in some ways, because as a child, I had really struggled with loneliness, and particularly in elementary school, where I often, I didn't realize then how many other kids did struggle with loneliness, but the most difficult time of the day was lunchtime. I remember when going into that cafeteria and wondering if you're going to be sitting alone was somewhat petrifying for me as a kid. But later on, when I was practicing medicine, I came to realize that even though I never learned much at all about loneliness and isolation in medical school or residency training, that so many of the patients I was caring for were in fact alone when they had to make really difficult decisions about whether to go on treatment or not for, let's say, a newly diagnosed cancer. I would often ask, is there somebody I can call to join you and join us in this conversation we're about to have? And they would often say, I wish there was, but there's nobody. But this became particularly relevant to me in 2015, 16, when I was serving as Surgeon General, because I found as I visited both individuals who were struggling with opioid use disorder, but talked to their families, that this theme of loneliness was so common. And loneliness, what we know about it now is that it's a stressor, that in our lives, it turns out relationships are buffers for stress, but isolation is a time of great stress for us and a trigger for stress because of evolutionarily how we developed as human beings who actually relied on one another for safety. You think about thousands of years ago, how when we were surviving really as small tribes and bands of people together, when we were separated from our group, so to speak, we were at greater risk of being attacked by a predator or dying from starvation from an unstable food supply. And so when we were lonely, in a sense, when we were isolated, when we were separated, we felt a growing sense of stress and anxiety and worry because our life was really at stake. And even though our circumstances may have changed in some ways, our nervous system is remarkably similar to how it was several thousand years ago. And that same feeling of anxiety and worry when we're separated from our group thousands of years ago actually still presents today. All of you know so well that that stress can be a trigger for relapse, and it can be also connected with overdose attempts and overdose deaths. And so what we know is that loneliness now is in fact a risk factor for both mental and physical health conditions, including, as I've seen it, opioid use disorders and addiction relapses across the board. But it's bigger than addiction. I just want to frame this before we move on, that this is not just a bad feeling, loneliness. It is now found to increase our risk of anxiety and depression, dementia, premature death, cardiac disease, and a host of other conditions that we care about, that we see often in the hospital if we're caring for patients, or that we read about if we're experts in public health. So however you cut it, it turns out that addressing social isolation, addressing loneliness is an important public health issue if we care about addiction, if we care about mental health, if we care about the physical well-being of people in our country.
Well, that's very compelling. And Vivek, you, I think, made this diagnosis about the epidemic of American loneliness back before COVID-19 came along. Deaton and Case, in their examination of the American experience, also pointing out the sense of despair that many people were feeling as a consequence of loneliness, as well as various economic stresses, and what seemed to be sort of collapse of social supports that used to be there for lots of people, the extended family, the church, and so on. And yet, if you were looking for a possible antidote to this crisis, you would certainly have picked some approach that was the opposite of what happened. With COVID-19 emerging, and now a little more than a year ago, causing us by necessity to isolate ourselves even more completely. How do you see that now? You're back as Surgeon General, you're seeing the consequences of what people have been going through from this unprecedented pandemic, worse than 103 years. Is the loneliness even worse now?
That's a great question, Francis. And you're right. This is the exact opposite path that we would have taken if we wanted to really build a more connected society, is to have a pandemic where people were, in fact, told that they couldn't see each other in person, and where many people actually came to be afraid of contact with others because of the terrible pandemic we're in. So I think there are many people for whom that sense of isolation and loneliness have actually increased during this pandemic. And interestingly, it's been a very heterogeneous experience, though, for the community at large. There are some people who have unexpectedly found themselves more surrounded by people during this pandemic as they bubbled with extended family or with a close set of friends. But that has been, in many ways, a luxury for many people who are on the front lines, who are essential workers whose job doesn't permit them to just pick up and leave and be with extended family, or to stay home and work virtually. These have been very stressful and isolating times. So I am worried, and I'm particularly worried about young people, about adolescents, about young adults who were already struggling with high rates of depression, anxiety, and suicide before the pandemic, and who are also struggling with loneliness, by the way. And I mention this in particular because it may surprise some of you. who might think, oh gosh, young people are so hyper connected by technology. They seem to be on TikTok and Instagram all the time. They seem to be chatting with their friends constantly. They're texting all the time. How could they feel isolated or lonely? But one of the things that has become increasingly clear over the years is that what matters when it comes to loneliness is the quality of your human connections, not the quantity. And for many young people that I spoke to over the years, as I traveled across the country, what many of them would say is, yes, we're connected to people all the time, but we don't necessarily feel like we can always be ourselves, or we're operating in a social media environment where comparison culture is really, at its height, and where we feel like we're always falling short in terms of the life we live, whether it's, not having a fancy enough job, or not having the stuff, the clothing, the other like accessories that other people have, or not having as many friends, or being invited to as many parties. And so I wouldn't be fooled by the quantity of connections that people have. It's really a concern over quality that has led to a great sense of loneliness for many people. And I think it's important for us to recognize this, because I do think that COVID, as painful as it has been, and it has been very painful, it has provided us, I think, a few opportunities that I would hope that as a country we will take advantage of. And one of those many opportunities is a chance to recognize that there is something deeper happening with loneliness and isolation in our country pre-pandemic that's gotten worse here, but which we can now focus on and address, because it has become a pain point in so many more people's lives. And doing that will be extraordinarily important. We talk a lot about resilience, right? In our country, we talk about the need for not just resilience in the military, where it's sort of a well thought through and considered theme, but increasingly you hear spoken about in the workforce among kids in education. How do we develop more resilient people? And while that is a fraught term in some ways, and I do think that one of the keys we have to recognize is that social connections are an important source of resilience. They are the buffers that we have, the natural buffers for stress. I mean, think about this. When hard things happen in our lives, so many of us just instinctively will pick up the phone to call a friend, or we'll get into the car and go visit a family member, or we'll look forward maybe to going to church or to synagogue, that weekend, so we can see people that normally associate with and trust as community, and so we can talk to them. We may do various things, but we often look for human connection in some way. And the truth is, if we want to build a society that's healthier mentally and physically, that is more resilient, and that is also very importantly more happy and fulfilled, we have to think about how we build a society that's more centered around human connection and around relationships. Francis, I think about this, when you and I were, going through our training, right? If I remember, if I came out of training, residency training, and I said to someone, I'm going to be going to a small town in America, far, far away from my family, but there's an amazing job opportunity there, an incredible job opportunity. And I'm going to be given a spot as an associate professor right out of training. People would have said, wow, that's amazing. You should go for it. But if I said, I'm giving up a few amazing job opportunities to go back to Miami to live with my extended family and to practice there, then I know a number of people would have just silently sort of shaken their heads and said, wow, I guess he's not as career-oriented, he's not as driven, he's just giving up so much to be with family. To me, that's the opposite orientation of what I think we need to do to actually be a healthy, fulfilled society. I think the question for me, and I think really for society more at large, is what do we build our lives around going forward? The chance to get through this pandemic is actually a chance to redesign our lives. It's not just the chance to go back to how life was pre-pandemic. It's a chance to ask ourselves, what do we want to keep and what do we want to change from life in 2019 and before? And my hope is that one of the things that we will reevaluate, again, is the place that social connection and relationships have in our lives. And if we truly build our lives around people, that means designing workplaces that allow people to prioritize relationships. It means designing schools that equip our children with social and emotional learning and tools to build healthy relationships from the earliest of ages. It means thinking about public policy, not from just the standpoint of financial impact, but in terms of how it impacts communities and how it fractures communities in some senses. These are all part of how we would think about building a truly people-centered society. Now, we have an opportunity to do that now, but it won't happen by default. We have to very proactively think through this. And it starts with our own life. Like, with what does it mean, like, for each of us to live a truly people-centered life? What decisions would we make differently about work, about how we spend time, about where we put our attention and energy? And I say this with some degree of guilt now, looking back on my life and realizing that while I many times said that people were the most important to me, my wife, my kids, my parents, my sister, the truth is I was living a work-centered life. I was living a life where I put them after decisions about work. And while that may feel noble in some ways for those of us who are involved in professions related to service and health, the reality is that we can do more for other people when our emotional tank is full. And our emotional tank is most ably filled by the people in our lives, by the relationships that we have.
Vivek, those are profound and very personal words that I think we can all relate to. And those of us involved in public health and medical research, we are engaged in a noble activity, an activity that promises to relieve suffering and to improve quality of life, not just for ourselves, but for others. But if it's an unbalanced approach, then probably our effectiveness suffers as a result. Speaking as somebody who's been a little unbalanced in the last 16 months, I resonate with your words because of the way in which this has been such a consuming circumstance. But we are not at our best if we allow ourselves to be totally consumed. Let me ask you about another vulnerable population that we care deeply about at HEAL because of our joint focus on the opioid crisis and on chronic pain. So we have to remember these 50 million Americans who are living with chronic pain, invisible to many, especially during the pandemic, for whom this experience of being even more isolated has to have been particularly rough. And also perhaps in a circumstance where getting access to medical care has been challenging. Things that you might want to say about that group from your observations as Surgeon General. Obviously, we need to bring forward to those folks more options than what we currently have to offer, although that's a big focus of HEAL. But they are deserving of our close sympathy and attention, even though society oftentimes doesn't want to hear from them because of the fact that this is not something that's just going to magically get better. Is that something that you as Surgeon General are also looking at, the folks with chronic pain?
Yeah, it's such a good question, Francis. And you're right. The populations that were vulnerable pre-pandemic have really struggled and suffered during this pandemic, particularly those vulnerable populations that have been living with an opioid use disorder and have found it even harder to get care, whether that's the medication-assisted treatment they rely on or the counseling services or the social support from support groups, which is an essential part of the overall sort of treatment approach and staying in recovery. So I do think that has been markedly more challenging. And to me, it's a reminder of how urgent it is for us to, number one, improve access to healthcare in our country, which we've made huge strides on in the last 11, 12 years, but where we still have much to do because there are millions who still are out of reach of the healthcare system. It's also a reminder of the urgency of integrating primary care with the treatment of substance use disorders. Everyone on the call today is so well aware of how fractured our system has been in terms of providing treatment. And it's particularly those who are most vulnerable who will find it most difficult to navigate a fractured system where you have to go one place for your primary care, another place weeks later for your MAT, another place for counseling services, another place for group support services. And so bringing these pieces together in a way that's easier for people to access is so extraordinarily important. But Francis, you mentioned something in the very beginning about a potential silver lining or sets of silver linings during this pandemic. And I think telemedicine, which you mentioned, is one of those, which I think has extraordinary potential to improve and extend access to services for people living with substance use disorders. In 2016, when I visited Alaska, I remember visiting a small fishing village called Napaskiak. This is a small remote village that you can only get to by boat or plane. There are no roads to Napaskiak as it so goes. And in that small village, though, of 150 people, isolated as it was, I walked into this small cabin where they had first aid supplies and provided some basic medical care. And there I saw a small monitor mounted on the wall. And I pointed to it, I said, what is that monitor for? And there was a chair in front of that monitor. And they told me, they said, that is the monitor where people come and sit and they can actually get counseling services if they're dealing with a substance use disorder from people in the lower 48 states. And I was so struck by that because, of course, sure, I'd heard about telemedicine, but to know that it had the potential to reach this remote village in Alaska, to see that actually in the works was just really extraordinary. But that was more the exception than the rule pre-pandemic. And I think the pandemic has accelerated our adoption of telemedicine by perhaps 5-7 years, or if not more. But we have to sustain that with not only the investment in broadband infrastructure and with the tools so that people can use it everywhere, but also with other things that seem mundane, like the reimbursement structure around telemedicine, which, I talk to clinicians now who are saying they are seeing some private insurers pull back on reimbursement for telemedicine because the pandemic, they feel, is starting to get better. But the lesson learned is not that telemedicine should go away. It's that we should be integrating even more deeply into how we practice for all conditions, not just for substance use disorders. The future of care, I believe, if we do this right, is bringing care closer and closer to where people are, integrating it into their workflow, bringing it to their homes and to their neighborhoods. And that is particularly how we will help vulnerable populations who may struggle with housing, with transportation to get to appointments. I still so clearly remember many of the patients I cared for who fell into that category of being really in vulnerable populations. They were working 2-3 jobs, trying to take care of their children at the same time. I mean, having a conversation with them about how they could find time to go to the gym was almost a laughable matter because they were literally dealing with issues of survival and putting food on the table for their kids. And so I think as a society, we have to do more to understand the lives of people who fall into those categories, to provide services that bring what they need to them, as opposed to expecting them to come to us. And many of the developments, and we may even talk about this, around trying to reduce barriers to buprenorphine prescribing, trying to actually enforce the parity laws, passed in 2008, which were meant to ensure that care or provided for substance use disorders is reimbursed adequately. This is why all of this makes so much of a difference, and why it's so important, as well as changing fundamentally the payment model in our healthcare system, which started certainly and was accelerated by the Affordable Care Act, but needs to continue, because if we continue in a purely fee-for-service-based environment, in a fractured system where people have to go multiple places to get their care, we will not ultimately get care to the vulnerable populations that need it the most, that have struggled the most, and that are hoping that we will do better this time around. I think we can, I think we must, and I think COVID may just be, in part, the impetus to move forward in a different way that we need.
Those are really important points you're making. And since the HEAL investigators are all very much devoted to the idea of carrying out research that will produce evidence for what works and what doesn't work, let's talk a minute then about the specifics of the opioid crisis, which sadly has led to an even greater loss of life in the most recent period for which we have numbers, COVID-19 undoubtedly contributing to that. But if we're going to turn this around, if we're going to move this crisis in the right direction, as opposed to where we've been here with the pandemic, are there particular areas, Vivek, that you would say we really need some more rigorous data in order to convince the medical care system, both the practitioners and the people deciding about reimbursement, that these are things that we must do, as opposed to, well, some people think this works and some people say it doesn't. And again, I think the HEAL Initiative has as one of its major mandates is to try to provide that kind of rigorous data in a fashion that you unmistakably can see what is really working and what therefore ought to be made available, not just to a small group of people in your clinical trial, but to all those folks who are at risk or are suffering from this crisis. So yeah, do you have sort of a short list of what are the things you wish that we had stronger evidence for? And it'd be interesting to do a crosswalk with that and what all these HEAL investigators are doing and talking about over the course of the next 3 days.
Well, that's a great question, Francis. And again, one of the reasons I'm so grateful to this team for doing the research, for being on the cutting edge. helping us understand more what works and build an evidence base to really push for investments in the solutions. There are a few areas that came to mind, and I've jotted down a few here, but I think building on what you were saying about vulnerable populations, Francis, I think it's so important for us to do research particularly targeted at these populations, recognizing they often get left out of clinical trials and studies, but being able to not just include them, but being able to have specific studies on vulnerable populations so that we can better target interventions to them is actually, I think, essential. The second place where I think we really could benefit from more rigorous research would be on prevention programs. In 2016, when we published the Surgeon General's report on alcohol, drugs, and health, we devoted an entire chapter, which was chapter 3 at the time, to look at these prevention programs, particularly school-based programs, which have over time been shown to reduce not just substance use disorders in kids over their lifetimes, but also a host of other benefits, from teen pregnancy to encounters with the criminal justice system, to improving graduation rates, to a whole host of other outcomes that we care about. But what would be very helpful is actually to take, I think, another pass at that body of research and see how can we take this to scale. How can we look at the circumstances that allow some of these programs to succeed versus ones that don't? How can we do more cost-benefit analyses to make the financial case as well, that the investments made are a small fraction of the benefits incurred in terms of reduction in healthcare costs, criminal justice costs, and lost productivity? So these are places where I think there could be enormous benefit. One of my disappointments, frankly, after the 2016 report was passed, even though I was grateful that the communities really took that report and did a lot of good with it, especially around expanding treatment, is I feel like we didn't get nearly enough done on the prevention side. And to date, I've not met somebody anywhere in the United States who said, I'd rather get diabetes first and then treat it later versus prevent it in the first place. People want to prevent illnesses, and as basic and silly as that might sound, it is the exact opposite of how we finance health interventions in our country. We put the lion's share of our dollars in treatment. We do very, very little in prevention. And we keep doing that again and again and again and again. Even if you look at the opioid crisis and you ask the question, what are the major initiatives that we have funded on the prevention side? They really are a small fraction, really, of what we've done more broadly. So this is a place where I think a community of investigators could be an important part of helping us to push for greater prevention, which ultimately will save money and, most importantly, save lives and relieve human suffering. A couple last things I'd mention also. Many of you I know have been following the buprenorphine, sort of world and what's been happening with the X waiver, with some measures that were taken at the end of the Trump administration to make buprenorphine easier to prescribe, and that was revised and now recently reissued by the Biden administration to again make it easier for people to prescribe buprenorphine. Now there have been requirements removed for the training, and which will allow practitioners to still have to submit and register for the waiver, but they can now treat up to 30 patients without having to go through the time-based requirements for the X waiver. So these are all important progressions. But the real question that I have, and the data I feel like that we need to accrue more, is: does this make a difference? Are more people actually going to then start prescribing buprenorphine? That limit of 30 as well. How critical is that? If we have the vast majority of people who sign up, end up treating 15 to 20 patients or so, okay, then maybe that 30 isn't a limiting factor. But if many people hit that limit of 30 and they want to actually treat more, then we may have a greater challenge on our hands. The other piece that I think that I worry isn't paid enough attention is the question of: what do primary care clinicians, who we know we want to be at the heart of providing a lot of these treatment services, what are the barriers they are facing? And I'll tell you, just from my conversations with primary care docs around the country, the buprenorphine waiver is not usually the number one thing that's preventing them from prescribing and treating people with opioid use disorders. They worry about, for example, not having enough in the way of social work and social support services in their office that they can provide to patients. They worry about not being able to provide the counseling services in their offices, or not having a system of availability in their community to ensure that if they start treatment, that somebody will have the full array of treatment available to them. There are various concerns that primary care doctors raise, but I actually don't think that this is well understood. by policymakers and research there to help us understand what are the barriers to primary care providers, providing treatment. What impact do these changes to the X waiver have? I think this would be immensely helpful to help us really design policy that's informed by evidence, more so than ever. Finally, the last thing I'll just mention, Francis, is it is become extraordinarily clear to me, and I think to many others, that social support is one of the critical elements of treatment for substance use disorders, that it's what helps keep people in recovery, and that not having that support, being lonely, becomes a source of stress, and that stress can be a trigger for relapse. And so one question is, what are the models out there for providing that kind of support that are truly effective? The AA model has been studied extensively for alcohol use disorders. But as we think more broadly about the opioid use disorders, as we consider the concept of recovery schools, recovery housing, recovery communities, just being able to understand more clearly with more directives, evidence-based directives, of how to help build the kind of community that people need, that is going to be immensely helpful, and not just at a large scale, but just even at a granular level. Like, I think about the fact that many people I met who struggle with opioid use disorders, they had family members who were wondering how they could be helpful, and they weren't sure. They said, should I just keep badgering my relative to go to treatment? Should I take a tough love approach? What should I do to be helpful? And this actually is one of the most pressing questions, alongside with how do we make buprenorphine counseling more available? Because again, that social support is so critical, and that support is most often going to come from family, from friends, and from other community members. So being able to guide them in an evidence-based way about what measures, what forms actually can be helpful to people struggling with opioid use disorders could also be immensely helpful to a group that is looking to provide assistance and support, but often is struggling to figure out how best to do that.
Great points. So one more question, and then I'm going to turn to questions supplied by the HEAL investigators. But this one, I think, has been such an important part of everything we're trying to do. You were focused as Surgeon General in the Obama administration on the importance of changing how America thinks about addiction, that this is not a moral failing, but it's a chronic illness that has to be treated with compassion, urgency, skill, and medical intervention. Are we getting anywhere with making that case, or are we still struggling against a sense that people who've fallen into opioid use disorder have of condemnation by those around them, as if this is somehow their fault?
Well, Francis, it's such an important question. And I think that sometimes people shy away from addressing those larger attitudes around substance use disorders, the stigma, if you will, around addiction, because it feels too squishy, too hard to address, hard to just pass a policy and change that, or run a clinical trial and intervene. But it turns out to be one of the most important barriers and issues to address, because if people are still feeling judged for their disorders, then they're not going to feel comfortable coming forward and getting treatment. They're not going to participate in their own care in the way we need them to. And others will hesitate to step up and provide support as well. And I still always remember the young couple that I met in Oklahoma who had lost their son to an opioid overdose, who told me that previously in their life, whenever they had a struggle, a job loss, other health issue in the family, neighbors would come over, they would drop off food, they would visit and sit with them in their living rooms and hold their hands to see if they were okay. And when their son died after an opioid use disorder, it was like silence. Nobody came over, nobody visited. And the neighbors, in part, didn't want to, I don't know quite what was going on in their head because I didn't talk to them, but it's a very common story of how people feel ashamed, they feel uncomfortable, they don't know quite what to say, and so they stay away, which is, it turns out, the worst thing that you can do during these times of great pain and distress. And so I do think we have made progress, though, Francis, in the last few years. There are more people stepping forward to tell their story. There are more people and practitioners who are embracing the importance of talking to their patients about substance use disorders and getting involved in treating them. And interestingly, Francis, I've encountered many primary care providers who have told me now, who've said, before I started providing, sort of treatment for people with opioid use disorders and doing MAT and doing the larger sort of set of interventions, they said these were the patients I dreaded the most because I felt powerless and I felt frustrated and I didn't know what to do. And they say now this is some of the most rewarding work that I do because I feel empowered. I feel like I'm really able to make a difference in their lives. I know how to help them. And I want to do more of this. And so I do think that we are making important progress. But the truth is, Francis, that we still have many people in the country who feel ashamed of what they're dealing with. We still have many family members and others around them who feel that this is a source of shame for their family, that they have someone who's struggling with a substance use disorder. And I think, to me, Francis, this is much bigger than about substance use disorders. This is a broader cultural issue of how we think about strength and vulnerability. And I think that we have defined strength in modern society, not just in the United States, but in modern society around the world, as the loudest voice in the room, the person with the most physical prowess, the person who's aggressive in negotiations and dealings, the person who's out there all the time and is famous and is getting lots of attention. That's what we associate with strength. But I don't think that that's what strength really is. I think strength is so often displayed in moments of vulnerability, when people have the courage to be themselves, to open up, especially when it's difficult. I think strength is defined by the people who have the courage to display love and compassion and kindness, especially when it's difficult. Those who are patient, especially when they have every reason to not be so. That's what real strength is. And if you have any doubt of that, think back to the people who cared for us as we were growing up, whether that was a parent or whether that was a teacher. Those moments of love and compassion, of patience that they displayed for us that helped us grow and develop and become who we are today, none of us would think of that as weakness. We would say that those are some of the strongest people in our lives. But yet we hold a different standard when we judge people in society more broadly. And I think that we do this to our detriment. And I think one of my hopes as a society is that we can ultimately redefine strength, that we can look at, as we think about our children and think about what we want them to be, that we cannot aspire for them to be the loudest voice in the room necessarily, but aspire for them to be the most thoughtful, the most welcoming, the most inviting, the most compassionate voice in the room. And I say this, Francis, not as a Surgeon General or as a doctor. I say this as a parent, first and foremost. I think about my 3- and 4-year-old, and I recognize, despite being the overprotective parent that I am, that I won't always be there to prevent bad things from happening to them. And what they and what all of our children rely on is a world where people are willing to give them the benefit of the doubt, where they're willing to help them when they stumble, when they're willing to lift them up when they fall down. That's a world that's driven and fueled by compassion and kindness. And that world can only exist if we value that, if we see that as a source of strength, if we see those as attributes worth striving for, that we want to not only embody ourselves, but that we want to teach our children. And those have to be values that we also hold up in other spaces. We have to value those in the workplace. I don't know how many times, Francis, I've seen people in medicine, in academic medicine, get promoted for being kind and compassionate physicians. I've seen plenty of people get promoted for the amount that they publish and for how much money, grant funding they bring in. And all that is important, don't get me wrong. But what message does it send to medical students when time and time again they see people's contributions on the human side discounted, and it tells them that it doesn't matter, right? So if we truly want to be a society that's grounded in love, compassion, kindness, if we truly recognize those as sources of strength and healing, we have to value those in our workplaces. They have to be reflected in our promotion systems. We have to value that in the classroom. That is to be reflected in how we evaluate our children as well. And we've got to ultimately build our lives around that. And this is everything from who we hold up in these institutions to who we hold up at the ballot box. It bothers me deeply when I hear people say, well, I fundamentally disagree with the values of that candidate for mayor, but I'm going to vote for them anyway because they're going to pass a policy that I like. That might be fine on a policy level, but what message are we sending to our children when we support people in society who don't reflect our deeper values? The values that ultimately make society work, those human values that unite us fundamentally, that we're taught in scripture, if we are people of faith, as you and I are, Francis, but even if you're not a person who subscribes to any faith, these are the deeper human values that have guided and sustained us and supported us for centuries. So to me, that is a broader lesson that I took from all of the conversations I had with people who struggle with opioid use disorders over the years. What I took was that yes, we need medication-assisted treatment. Yes, we need counseling services. Yes, we need social services and wraparound services and recovery services. But the fuel, the engine that will drive our healing is fundamentally the love and compassion that come from human relationships, whether that's people you've known for decades and decades, whether that's a stranger that you encounter, or whether that's a work colleague. We all have the ability to heal because we all have the ability to be kind and to love one another. And that to me is the lesson that it took me more than 2 decades to learn in medicine, that more important than any prescription I could write was the compassion I could extend to a patient simply by listening to them, by showing up, by being present in their lives. And we all have that ability, regardless of what degrees follow our name.
Wow, Vivek, that's such an important set of principles, and also, I guess, a bit of a diagnosis of what seems to have gone awry in not just parts of our society, but much of it in terms of the fracturing of social relationships that has led to so much isolation and distress and contentiousness. And yes, the loudest voices certainly do seem to be the ones that occupy most of the screens that we all look at, and there's a better way. So I really appreciate your walking through all of those principles so clearly. And it's wonderful to have you as our Surgeon General standing up for that perspective. So I do see a few questions coming from our HEAL investigators. One comes back to your discussion about providers and what are the issues that are getting in the way of providers. And you mentioned a number of practical ones, but what about stigma? Not for the patients they're taking care of, but for the providers themselves. What do you think is driving that? And how could we help get that particular obstacle out of the way?
Well, it's a very thoughtful question, because this is something I think people on this call appreciate, but I think the broader public does not. And I would venture to say many policymakers may not either, which is that stigma within the profession itself that prevents many people from wanting to treat those with substance use disorders. I think that's real. I think it's still present. But I do think that the ways that we get around it are, number one, we make it easier for clinicians to treat people with opioid use disorders. And that means we've got to train them. We've got to provide the support and resources. The second thing is we've got to hold up and champion the people who do it and do it well. Medicine is interestingly very good at shining a light on practices that it likes, right? Like we have so many forums to do that. We promote people, we call them out in morning report in the hospital, we write them up in journals, we do so many things, we give them awards and recognitions. We do a lot to recognize the practices we care about, but this is a place where that could make a big difference as well. That's a part of how the culture in medicine changes. So I would love to see more hospitals, for example, profiling primary care doctors and others who are providing care for those with substance use disorders, and telling the good story, not just portraying them as somebody who's doing the hard work that nobody else really wants to do, and thank you for stepping up when no one else wants to go. But more so, look at this person who's found an extraordinarily rewarding pathway and they're serving at the same time. How do we build more of that? Let's look at what they're doing. I think that is a big part of what has to happen. Look, I don't think also that financial incentives are something to write off either. I think we use financial incentives all the time in medicine, right, to promote practices that we like, right? We try to provide reimbursement for services we think are essential. But I do think that here too, that we have to be thoughtful about how we reimburse for care of substance use disorders. The parity law is not enforced adequately across the country. And so people who often provide substance use care do not get adequately reimbursed for it. And as one addiction specialist told me when I visited Indiana some time ago, he said, look, I have medical students who shadow me, and they see how hard I work, how little respect I get in the profession, and then how little I'm paid. And then I turn around and ask them if they want to join become an addiction medicine specialist later. And they look at me and they say, are you kidding me? After everything I've seen? And that's the reality still in many parts of the country, but we can change that by making it easier to treat, by holding up the people who do this work well, reimbursing better for the services. That's how we shift things in the culture of medicine.
That's really important. Okay, one more question. One of the greatest needs with respect to the overdose crisis is criminal justice reform and humane and evidence-based treatment of people incarcerated. How can NIH, CDC, and let's just say the Surgeon General influence policy and care in the criminal justice system, which seems to be mostly an opportunity that's wasted?
Yeah, gosh, such an important question. And everyone on this call, I think, has likely been frustrated, I'm sure, at some point with the lack of progress we've made in extending treatment and, frankly, prevention services to people who are incarcerated. There has been progress, no doubt. Treatment courts, I think, have been extraordinarily helpful in many parts of the country. The research that has been done, including by, I'm sure, people on this call, has helped shine a light on how fractured the services are in our prison system and how difficult it is to get people care after they leave the prison system when they're at extraordinarily high risk of overdose deaths. And progress like we've seen in Rhode Island, for example, in recent years, like it has been useful in saying that there are models that we can pursue to better treat people who are in our prison system. But look, there are a couple of things I think we're fighting against. One is, I think, an unfortunate stigma where people, still too many people believe that if you're incarcerated, then your life is inherently less valuable or you're lower on the priority list, right? And we are, just, to name it, that is still a challenge we are dealing with that leads these populations to be, I think, deprioritized in our public policy interventions. But I think second, I think there does need the research that's done not only showing the health benefit, but the cost benefit of intervening effectively and treating people, in the prison system who have opioid use disorders. I think that is absolutely essential. Look, you hope that you can, on the measure of values and just sort of human compassion, that you can make the policy arguments. But sometimes you got to make it on the cost basis as well to move everyone who needs to be moved. And so I think research that helps us understand even more and make the case even more about the cost impact to financial cost impact, the broader societal impact of getting this treatment right in the prison system and then after people leave, I think is also essential. And one last thing I'll add here, which is something that may be uncomfortable for some of us to do, is our advocacy as well. Science is only as good as its ability to be applied, right? And we know that the ability of science, look, in and of itself has intrinsic value, right? Like we know that advancing understanding, pushing us to ask deeper questions is extraordinarily important. But I have a feeling that nearly everyone on this under this call rather, is excited about what science can do when it's applied as well, right? And into what it can do to actually change people's lives. And what is probably extraordinarily frustrating to many viewers, is to me as well, is what happens when science can be applied but isn't, because it gets stuck. It either gets stuck, at the publication level, or it gets stuck without people, looking at it but then putting it aside on the policy level and feeling like, it's not that important to implement. What we need to do to prevent science from getting stuck, is we have to be vocal advocates. And that means that we have to speak to our legislators. We have to speak to whether that's at a local level or a state level or federal level, and not only be scientists, but be science advocates as well, to say, this is what the data is telling us. This has to be where we invest. And that involves talking to media as well. Francis is obviously a maven and a genius when it comes to talking to media, but I think that the world needs to hear also from scientists across the spectrum, scientists who are working on this research primarily, who are putting forward these findings. I'll just say that, and I'm trying to be careful about saying this, but like the world hears from people on topics all the time where those people have no expertise to really contribute. Right? There are a lot of folks talking about stuff that they frankly don't understand. You understand this topic better than the vast majority of people in the country. You're the ones I want to be seeing on the evening news, talking about what our approach should be to opioid use disorder. You're the ones I want to see quoted in the newspapers. And I realize this isn't how PhD programs and MD programs train our candidates in how to engage with the media and engage with legislators. But I do think this is one of those moments where we cannot rely on the research carrying itself, on compelling findings somehow automatically translating to change. We live in a world of competing priorities. And sadly as it is, the most effective advocates are the ones who enable action to be taken. Those advocates, I think, can be all of us on this call and our colleagues in science and medicine. And that's got to be a part of what we do to make the next phase of this much, much better, to save lives, especially for vulnerable populations.
Well, that's a wonderful exhortation for you to leave with this group of 700 investigators who do have knowledge that is much deeper than most of the rest of the world about this crisis and what we can do about opioid use disorder and chronic pain, and how we can better help those who need that kind of assistance by the best possible science, and then making sure when we have the science that it gets out there and it actually changes practice and helps save lives. Vivek, this has been a wonderful conversation. You are a remarkably articulate purveyor of all kinds of important information and deep principles about how best we might live our lives in the midst of all the stresses around us. Your remarks there about what it means to be a person of strength, I couldn't help but think reply so beautifully to yourself, that you are not the loudest voice, even though you have the chance to be as the Surgeon General of the United States. You are making yourself vulnerable, you are personal, you are manifesting what we all need to do more of, which is love and compassion. And so we are fortunate indeed to have you at this time where we need lots of love and compassion as our Surgeon General. So thank you for your generosity in giving a full hour of your time to this conversation to encourage and inspire the HEAL investigators, who I am quite sure have been encouraged and inspired by this conversation. And I hope we can continue close relationships with you as the science moves forward and we seek better answers to help those who are still waiting. So thank you, my friend. It's been wonderful being able to have you as part of this program.
Well, thank you so much, Francis. So appreciate your friendship and partnership on so much of this work. And thank you for your leadership in helping move this area forward, especially when the country hasn't been as focused on it. My appreciation also to everyone who's joined this. I realize so many of you are toiling, and sometimes it might feel like in obscurity as the world is constantly focused on COVID, but we need your work, we need your expertise, and we need your voice. And I think we are at our strongest, as people of medicine and science, when we are leading unabashedly with our values. And the truth is, the issue that you were so focused on addressing, opioid use disorders, this is not just a health issue, this is a moral issue. It's an issue about how do we treat those who are most vulnerable? How do we treat those who are unwell with a chronic illness that any of us could be susceptible to if circumstances were different in our life? And the lesson that the country takes from how we handle opioid use disorders, I think, will have ripple effects on other health areas as well. So I just appreciate everything you're doing. I'm so grateful that you're here, and I'm certainly here to assist and support in any way I can. I've spoken with with many of our folks in our administration, including much of last year with President Biden, about the fallout effects of this pandemic on the opioid use disorder universe, and how we were going to likely see an increase in overdose deaths and see more people struggle with behavioral health across the board. I know that he's very aware of that, very committed to addressing this issue, as Francis knows as well. And so I'm hopeful that we will have a good partner, a good set of partners across the administration as we look to address this. Thank you all so much. Thanks for having me here.
Thank you so much, Vivek.